The panel features three speakers. I think we're waiting for Lee Kim to join us from HIMSS, but while we're waiting, I will introduce Dr. Michael Kirchhoff, who serves as Chief Innovation Officer at Cooper University Health Care, where he continues to practice emergency medicine while leading the commercialization of clinical innovations and driving external business development partnerships. He also holds the role of Patient Safety Officer for the health system. Dr. Jeff Leake serves as Vice President and Chief Data Officer at FHIMSS, where he leads the implementation of an enterprise-wide integrated data science ecosystem. He is also a professor of biostatistics in the Public Health Sciences Division, recognized for his contributions to genomic data analysis, online data science education, and for spearheading the Cancer AI Alliance to accelerate cancer research. I saw Lee Kim pop in there, so I'm sure she'll be here shortly. So I'm going to introduce her. She is a senior principal for cybersecurity and privacy at HIMSS North America, where she advises on healthcare cybersecurity, privacy law, and critical infrastructure protection. She is a highly recognized thought leader who serves on national advisory groups focused on advancing cybersecurity education and policy. And last but certainly not least is our moderator for this discussion, who is Justin Barnes, a seasoned healthcare growth executive and industry strategist who brings deep expertise from Silicon Valley startups to Fortune 5 and global corporations. He also hosts the nationally syndicated award-winning This Just In radio show that airs on our own Healthcare Now radio station. All right, Justin, I'm gonna stop my screen share and go on mute, and welcome all, and I will go ahead and turn it over to you.
Perfect. Thank you very much, Carol. I'm grateful to be here with everybody. Hopefully everybody can hear me. Use the video on, Carol, here, just to make sure
you're excellent. Good. You're good to go.
Perfect. Thank you. So again, thank you everybody for being here, and certainly grateful to join this panel and host this conversation here with you. We specifically created this panel to give healthcare organizations and healthcare leaders a practical playbook for starting and scaling AI, hopefully focusing on real world strategies, not hype. So for many, knowing where to begin can feel overwhelming. So hopefully we designed a discussion here to establish a scalable starting point for your AI adoption. Specifically today, we'll cover core strategies needed to lay a strong foundation for digital health, highlight best practices for safe and effective AI implementation, and provide practical guidance to help everyone avoid common pitfalls while preparing for long-term AI success. Carol introduced our speakers, Dr. Jeff Leake, Lee Kim, and Dr. Michael Kirchhoff. So grateful to be here with you gentlemen and ladies. And so why don't we go ahead and dive in? So, this is probably for everybody. And I'll start off with you, Lee. As we know, hospitals and health systems are under enormous pressure, care quality, cost reduction, staff burnout. So why do you think AI has become such a central topic in addressing these challenges right now?
AI is certainly a tool that can force multiply our use of data and what we could do to solve, frankly, really tough problems in healthcare. So it's being embedded in hardware, it's being embedded in software solutions, and regardless of our healthcare organization's stance on it, vendors are already incorporating it as our hardware manufacturers. So I think that it's definitely something to contend with as it's becoming part of our technology infrastructure.
I agree, it's excellent. Jeff?
Me come off mute. Yeah, I think that for me, certainly as a chief data officer, I get a lot of questions about this. And I think it comes down to there are a variety of tasks that people either believe AI can do, whether that's true or not, or that AI can actually do, that are perceived as ways to reduce burden on providers, on patients, on researchers in the case of the Fred Hutch. And so there's a lot of demand, and people have certainly seen how AI has played out in other industries that can move a little bit faster than healthcare. And so I think there's also a little bit of FOMO, a little fear of missing out on the AI innovations that are happening in spaces that are maybe a little less regulated and have a little bit less requirements for safety. And so I think the combination of those things is driving a lot of interest and a lot of opportunity. But to your point and the point of this session, sort of separating the hype from the reality is a big challenge for anybody in the kinds of roles that those of us on the panel hold.
Yeah, I agree completely. Michael, what are your thoughts?
Well, first of all, I like to think about AI as just another tool in our armamentarium about things we can do. And one of the things for me clinically is really watching nurses and doctors really struggle with the volumes that we have, et cetera. So for me, AI is a productivity lever, plain and simple. If you look at the 100,000-foot view, labor markets tightening up, hard to find good talent, everybody's growing. We have eroding margins on the payer side. Things are getting more expensive. So at ground level, at the bedside, that productivity level is important too, because it's an anti-burnout initiative. It's a way to engage team members. We heard from the nursing panel, those nurses unburdening them from the work that they're doing so they could do the human things, have the humans do what the humans do best, and then unburden them from a productivity perspective for all this other things. So instead of the nurse spending half of a third of their day at the bedside actually talking to patients, they can spend 2/3 of their day. And same thing with the docs. Using productivity tools to do ambient listening for me, I can talk to the patient and listen to the patient and not have to worry about the work I'm going to need to do. In the past, it would have been 3 hours after my shift. Now it's done with a push of a button.
Right. Yeah. Excellent point. So Jeff, starting this off, you lead the Cancer AI Alliance as well and spearheaded that, and you've been recognized globally for your work. From your perspective, what's the first thing healthcare leaders need to get right when laying a foundation for AI?
This is always a hard thing to talk about because I'm a technologist at heart, and I wish I would come in and say that the technology is the first thing to think about, but it's almost like the last thing that you need to think about. And so the reality is that AI, like many of the technologies, and I like how others have talked about this, is a productivity multiplier and just another tool. And in some ways, that's very true. And so all of the usual components apply. You need to have careful governance set up so you understand what you're implementing, how you're implementing it, the right kind of agreements in place, the right transparency with people about how these tools are being used. And the reality is your data and technology infrastructure, if it's not prepared to use AI, it's very hard to just sprinkle some AI on top. There are a lot of vendors that are like, we're an AI company and we're ready to help you out. And then the first thing they say is, well, certainly you've got your data all structured on a cloud environment with all the right APIs enabled. And you're like, well, that's like, 7 years of engineering work that we haven't done yet. And so there are these really foundational components in infrastructure, whether that's technology or data, in governance, to make sure that there are the right systems set up to be able to make decisions. We had to set up a whole AI review committee to enable these sorts of applications. And then also really from a financial modeling perspective, because these tools usually are consumption based and they can lead to a, short term, the pilots tend to work out really well. They don't cost very much, but once you scale it to the whole enterprise, this is a non-trivial cost to those organizations. And so the financial modeling is also really important. None of that is the fun AI technology stuff, but it's so important to do those pieces right to have any chance of success. And then the other thing that I think people need to think about, and certainly we're struggling with, is the big difference between AI models and a lot of other technologies is usually when you use, say, a clinical decision support tool, it has a somewhat deterministic output. You put in the same patient parameters, you get the same output. Some of these AI models, they have these probabilistic outputs. And so the outputs aren't always exactly the same every time you put them in. And that can cause challenges if you want to sort of pay attention to both regulation and documentation about what's going on. And so paying attention to how do you manage probabilistic tools is probably something that isn't really comfortable for a lot of organizations and takes a little bit of upskilling and training of the enterprise to understand what those tools can and can't do.
No, fantastic. And you just covered this a little bit, but what are some of the common mistakes that you see in organizations that jump in a little bit too fast? And we heard about that, some of that even earlier today, but especially around data quality, validation, governance. What are some of your thoughts there?
Absolutely. I think all of those are, those things that are sort of the foundational components. Really, if you haven't put those in place already, you have to make those investments to really have the AI pay off. And so what I think I've seen a lot is that organizations want the AI magic, but they haven't been willing to kind of put in the hard work to get to the point where they can use those AI tools. And so that could be as simple as making sure your infrastructure is set up in a way to work with vendors. It could be as complex as having to set up entire new data ecosystems and new governance pathways. Kind of depends organization to organization. But the two things I would say, the two failure modes I've seen most common are the data or technology aren't ready, or there isn't a clear articulated governance process for installing, managing, dealing with the outputs of these tools. I think those are the two places where I've seen the most sort of failure modes. And then the third one is pilot fatigue, where people do a bunch of AI pilots but can't actually scale them. Those are the three, I guess, that I would say are the most common ones.
Yep, excellent. And I think also one thing I've heard recently, and even a little bit today, is the use case. Is really understanding what your use case is. I think doing AI for the sake of AI, we've heard over a dozen times now, is it's not beneficial, but certainly understanding what your use case is for your organization, your care strategy. Excellent points. So Lee, you spend much of your time helping health systems navigate cybersecurity, compliance, privacy. From your perspective, what are the main tenets healthcare leaders need to get right when laying the foundation for AI?
So I wanted to pivot it slightly by qualifying that within our healthcare organizations, we are already using AI. Certainly in radiology, for example, AI has been adopted for quite a while in terms of the computer-assisted analysis, and in some instances, AI can be even at the imaging modality in terms of detecting things like masses and other anomalies. So notwithstanding that, though, I think that the question is in terms of mass implementation of AI across the enterprise. This was previously said, but I can't emphasize enough that, and this is taking the page of Fortune 100, 200 companies that are around the globe, and I've spoken to them also about their AI programs and what's happening. And the basic thing is, I think that healthcare organizations can follow the lead of these Fortune 100, 200 companies by, as was mentioned, setting up that AI governance committee. And we need to approach AI as an enterprise systemic thing because that's how ultimately it will be deployed. Do you have all the members of your executive leadership team on your AI governance committee? Do you have your major stakeholders, including the major representatives from your significant lines of business, and even a rotating set of clinical leads? Because, of course, this might touch healthcare. And also, are your CMIOs and CNIOs and your informaticists, are they on board as well, as they need to, of course, make the bridge to your physicians and nurses to communicate things relevant to risk and what tools can we use? I think it's very important for organizations to start small when they are building the foundation. So to understand what the use cases are initially from a conservative perspective, what from a risk perspective do we first start with? In some ways, this kind of reminds me of when organizations were going to the cloud with their EHRs and everything else. A lot of more mature companies had started with, for example, some small, low impact things. And even in healthcare, just like radiology and other things, you have to start first with things that are perhaps repetitive, low risk, but take tons of time. AI, of course, is a tool as to efficiency, but of course, as the level of sophistication or complexity of analysis and/or output goes up, you will also need to set fixed standards about when will there be a human intermediary to evaluate what's happening? Is there perhaps an override switch that I can do vis-a-vis AI? So equally tied to, of course, laying the foundation is ensuring that your procurement department is represented and that they also understand where the various ramifications are regarding AI. It's not a question of where it'll spread or how we adopt it. It's more of a question of how well do we organize it, organize our people around it, make our workforce ready to use it, and also the extent to which we can responsibly deploy AI solutions to our patients, because it's not all the same.
That's fantastic. And one thing I want to pick up on that, Jeff, and you touched on a little bit, is also the data and your data sources and really curating your data sources, because you don't want to just be pulling from information from anywhere. And a lot of people have these ecosystems set up or databases set up, but that's something that I've seen a lot of best practices, just understanding that you're peer reviewed or wherever you're pulling your data from, your information from, that it's a trusted source. And this is what, Jeff brought up before, is you may have to start over, you might have to restart, but it's very important to get that data set right from the beginning. So I love that. So following on this, Lee, what key steps should hospital leaders take to ensure trust, transparency, and data security in early AI adoption?
I think in terms of ensuring trust, we have to understand that in terms of adopting AI tools and other infrastructure, again, by and large, this is either custom built in-house
Mhm.
or it is bought. So if you are procuring third-party solutions, of course, it can't simply be an RFP that goes to the lowest bidder. Because again, in healthcare, patient safety is at risk, the quality of care is at risk. So we need to be very careful about the solutions that we choose. But just the same, I think that it's very important for us to understand that we are in a time where these AI solutions really matter in terms of what we pick and choose to implement. And I don't know, I just think that it's a very conscious thing for us to move in line with enterprise needs. And I'm sorry, if you don't mind repeating the question again, I would appreciate it. I
Yeah,
lost.
sure. No, it's really understanding. Yeah, trust and really understanding trust in value chain and understanding transparent data security. That's
Yeah, I think that there needs to be a distinction drawn between, I think that there's an overstatement regarding explainability and transparency of AI models. From a technical algorithm perspective, I would like to push against that. I don't think that it's always needed or necessary. I think that where it impacts one's function, I think that where AI can't be overridden and or the analyses or output may be questioned, I think that that's where we need to understand how to interact with the model, to nudge it or to modify it or give the developer feedback. I think also in terms of homegrown tools, we need to make sure that there is always a feedback loop with the stakeholders or whomever the primary users are. And I would hope that even with third-party solutions, that there is that feedback loop as well. So again, is technical understandings of all the different things that can happen and the errors and the unavailability of resources and other things that can happen that can influence what AI does, is that necessary? I would contend no, because then we all might have to get PhDs in AI and go through years of study. So I would say you just simply need the level of explanation to essentially do your task and also lend input to whomever the manufacturer or developer is of the solution itself.
great points. And I know, Michael, Dr. Kirchhoff, you're gonna have some thoughts here too. So, as Chief Innovation Officer and Patient Safety Officer, you're responsible for balancing innovation and safety there. How do you think about deploying AI with increasing clinical and operational risk?
Yeah, that's a really great question. And we've heard it, Jeff mentioned about governance and Lee mentioned about overriding the AI.
Yeah.
And it really comes to understanding the risk of the deployment, et cetera. And there's a ton of really great risk management frameworks out there. You can just look them up. And Chai's working on a bunch. So, there's plenty of information out there, but you have to actually read them and then think about what the implications are. So the first step is, if you're going to deploy a technology, you have to understand that risk. And as a technologist, as a chief innovation officer, I also have, I don't know, dubious honor of also being the patient safety officer. So if these technologies go sideways, I'm the one doing the investigation. So it makes a lot of work for me, and I really want to focus on that. But even if you don't have one person doing both jobs, really what you need to do is have those stakeholders in the room. We've talked about risk management, et cetera. So you want your risk managers, your law team in, you want your regulatory team in to really look at that as part of your governance. If they're not part of your governance, if your governance group is a bunch of informaticists and a bunch of IT professionals, you don't have a governance group. You need these other people in there. And then what you need is an accountable C-level person to then say, okay, I understand the risk. So, our CISO will always tell me no, because that's his job, right?
Right.
But then we have to say, okay, now, but this is the upside to this. Let's have an adult conversation about what the real risk is, what the probability of that risk is, because it's not just the impact, it's the probability. And then as a group, make a decision about what that that true risk is, and is the upside outweigh the potential downside risk. And you need a multidisciplinary group to do that. If you don't have a multidisciplinary group, you're not going to do that. And I think most of the risk management frameworks really talk about that. And from those frameworks, the thing I'd like to talk most about, because sort of Lee alluded to it,
Yes.
is the two sort of human things. So I started this session by saying, let the human do what the human needs to do. And there's two things that the human really needs to do in AI. One is that human in the loop. So from a regulatory perspective, an AI is not a doctor, an AI is not a nurse. There are regulatory requirements at the federal and state level that human in the loop needs to be there. So when you ask the question, sort of what's the easiest first step, it's not only these sort of low stakes installs, but it's installs with human in the loop, where you have a licensed professional who's validating that output from the AI and doing a couple things. So one, we've often talked about the human in the loop around reinforcement learning, especially reinforcement learning with human feedback. But the point is, even if you're not training the system, that human in the loop looks at the face validity of the output, and that helps with that explainability and that validity of the output, because there's a professional there who's putting their license on the line to say, yes, this makes sense. So does it make my job easier? Yes. But does it make my job go away? No, because at this point in time, you need that human in the loop to look at these outputs and really understand it. So think about deployment and think about who needs to be at the table to have that first conversation. And then after you deploy, who's that human in the loop to for every single output, think about what is that output and does it have face validity and does this make sense to me? But that's only one of the two people I really consider super important in this chain. And that's what I like to call the responsible human. You'll see it in the NIST and HHS frameworks, but more it's around sort of responsible and explainable. Responsible AI deployment, it's not a responsibility of the human in the loop to make sure the AI is deployed properly. They're responsible for the output and what it does at the sharp end of the organization at the bedside. But the responsible human makes sure this system was deployed for oncology and I'm not using it in rheumatology, that there's not scope creep, that if there's an error, not from me, like if I, as a clinician, have poor judgment and the output doesn't have face validity, that's a human in the loop problem. But if there's bias that comes out, if there's drift in the system, either because it's not in a lifelong learning regimen, or there's new technology, or the reinforcement learning has resulted in catastrophic forgetting, whatever is happening with the system, you need that human in the loop, that responsible human, not the human in the loop, the responsible human. You have to have a person to go to. I can't go knock on the door of the AI's office and say, hey, this output's biased. I can't knock on that door and say, this output doesn't make sense based on this new literature. You were talking about, really trustworthy data sources for training. Those data sources, unfortunately, in medicine change daily, weekly, monthly, annually. There's always new data. The system always needs to learn. And the number one way to catch GPT is when somebody passes off the work, it says, as of my training date, right? Like that we see that in sort of in pop culture now.
Right.
You can't have that happening in medicine. And when the system's not keeping pace, when it's not sensitive to the changing nature of the work that we're doing, there needs to be a person in your organization that you can go to. Now, they may interact with the vendor, et cetera. They may interact with regulatory agencies, but the key aspect is the right stakeholders before you put it out there, human in the loop once it's deployed, and once it's deployed, that other FTE, and this gets to Jeff's point around like doing the work.
Yes.
And I talk about productivity, yes, it will make everybody more productive, but it's not, you still need FTEs to be a person to manage the deployment, make sure there's not scope creep, make sure the biases aren't there, et cetera. And you better hire that person, because if you tell an applications manager, you're going to do this plus all these other things, it will never get done. They won't be doing the work. It's a new job to manage and corral these AIs. And you better, your human in the loop's not going to do that for you. You're going to need those people. So it's all about people. If you want safe and reliable and explainable AI deployment, it's human in the loop, it's the responsible human, and it's the real people on the governance panels, not just your technologists, but your risk managers, your legal folks, nurses, and honestly, community, family members, patients. They all have a stake here, and they all their voices should be heard to understand how this is deployed and what the implications are.
Fantastic points. And here we got about 15 minutes left. I want to kind of jump around a little bit here. So let's start off with some use cases. Obviously very important here with AI specifically. So Jeff, go back to you. How would you, what are some of the safe use cases in your opinion for a hospital or cancer center?
Yeah, so I think safe is, again, a matter of degree. And I think that what Michael said is so important, that like the governance group cannot just include the IT, tech, and data people. If you do that, I think you're in for a world of hurt. You absolutely need your legal, compliance, and stakeholders, as well as potential patient advocates on those governance committees. Where I think you're seeing a lot of the fastest traction I'm seeing is not in direct patient-facing applications, which are the highest risk and require the most careful governance and oversight. It's more in back office type work, whether that's developing submissions for payers, helping to document with documentation, helping with sort of anything that's sort of a back office task that takes up a lot of time. I'm seeing that's where the adoption is quickest. And I think that's partially because the perception is that the risk is lowest. Of course, it's not zero risk and you still need that governance in place, but that's where I seem to see it the most. And then we're starting to see people inching towards things that are more sort of patient-facing and clinical-facing. Some of the vendors are not inching, they're accelerating and stomping on the gas. And so I think that's part of where, to Lee's point, in some places it's already happening and you're just trying to catch up. But I would say that the place where I see both what I would say is the perceived lowest risk and the fastest adoption is on anything back office,
right,
as opposed to anything that's sort of patient-facing.
No, excellent. That's also why we want to do this panel specifically, is just kind of give everybody a foundation and the confidence to begin some of these projects, hopefully, moving on the patient-facing side and the clinician-facing side. Lee, what are some of your thoughts there just around it? What's a use case that you work with that you would recommend?
I more advise on the policy end, so I can't really tell you
governance
about
framework. Yeah, a governance framework would be good. Yeah,
governance frameworks. So in terms of governance frameworks, I think that while you have your governance committee in place, it's very important to ensure that you have a very strong AI approval program in terms of what tools people want.
there you go.
Not only do they need to set forth things like the business case for wanting to have the AI tool, who they anticipate the users to be, why, perhaps some examples, some products, and of course the economics of that. But I think that it's very important also to have a very strong policy regarding acceptable use and also reducing the shadow AI footprint. I need not say all the dangers of shadow AI. That is going to really kill patient trust and quality of care, as well as privacy if there are no guardrails around that. So that's something that is very much needed. And I think too, something that's not discussed that we need to keep in mind is just like with cloud computing, everyone was going to the cloud. It was seemingly very economical. It seemed like to be a panacea. AI similarly is not a panacea, and it is not going to be as cheap as it is today. I'm certain that all costs will rise. And I'm going to say something that I probably shouldn't say, but I think a really stark reality of it is, whether it's administratively, our operations, our clinical care, we need to also understand what the budget forecast is for our AI solutions, and to ensure, of course, that unlike what the current situation is around tools in healthcare systems today, where there are conflicting and redundant tools, especially with larger systems, we don't want to be in that situation, because ultimately it can really hurt patient care. And while I also applaud things like ensuring that we have appropriate measures such as human in the loop, there will be a push from technology vendors for us to have agent-based AI where there is perhaps no human in the loop. And if there's a specific limitation I've seen across all kinds of companies, including healthcare, it's that we are not bothering to train our staff and contractors enough in terms of how to safely and responsibly use AI. It can't be something that's once a year or even once a quarter. I think that education should always be there and present. And we need to set standards about how we use it, what's safe and what's ethical. We need to keep in mind also, I'm seeing some questions in the chat. I don't mean to jump ahead, but I think that we need to keep in mind that what we understand as our coworkers and other workers today within our healthcare systems, that too may change. May I have an AI coworker in the future helping me clinically, administratively, or otherwise? Possibly. So we need to be flexible. And I think that we need to take a step beyond the great things that we're discussing today about, going to step one and implementing it and good governance and great execution and ensuring that people are overseeing the care of people ultimately. I think it's also very important for us to future seek and understand that what our 3-year and 5-year trajectory is in terms of this technology and where things are headed, and to be flexible enough in terms of our processes to not move iceberg style as sometimes healthcare is done, but instead keep change with technology and market forces and how the solutions that we have put in our hands indeed may be changing, and unfortunately at times may be much more vulnerable, which of course is more work for security teams and others to ensure that things are trustworthy and safe.
Yeah, no, excellent points. And to your point about, the need for education and staying on top of it, I, even upon myself, go back to school next week to Stanford to basically bear down on digital transformation and AI and put an AI playbook together with them. So completely agree about the importance of education. Michael, very unique perspective coming from you, obviously, with Cooper University and healthcare. What's a thought there from the innovation, how it's impacted you, or a starting use case from your perspective?
Yeah, I mean, if we're going to focus on easy, low-hanging fruit use cases that are low risk, to me, the number one place we're seeing it across the health system is communication, augmented communication, in-basket communication, text messaging, even text-to-voice for patients, care journey mapping around AI, and just letting people know where they are, updating them, etc. It takes a lot of the burden off the clinician or the person doing that work. Traditionally, we've hired FTEs to do that. Now that FTE can do something else, so you're generally clinical people that are helping manage those communications. The AI can help that. Now the clinician can do 10 or 20 of them easily. That FTE can go do other work like do a nurse helpline, etc., or take the error queue from the augmented communication workflows that the AI is managing. It's a great satisfier, and in some studies, humans actually prefer it.
Right.
You give the human you let them know. That's one thing we didn't talk about yet. When you deploy an AI, the end user, the consumer of that, should know it's an AI. So in everything you do, this is an AI. Patients have the option to opt out and have that human available for them. But also, it turns out that when AI is much nicer at writing replies via email than a doctor. Doctors are in and out as quick as they can. We're overworked. There's too much going on. We're not getting enough reimbursement. So we try to terse and we're on and we're out. The AI is much better. It understands the patient, it understands human interactions. You prompt engineer it with compassion, etc. And
Excellent.
Universally, patients prefer that tone over the native physician tone. We're terrible at talking and communicating. So why not do something that's better? And then we're ultimately checking it. It's low stakes. We're checking it before it goes out, but it's helping us. It's the AI is writing the first draft and we're editing it. That's just a great workflow. That's what I tell my kids to do at school. Just Yeah, the AI is a tool. And Lee talked about it. That's why we talk about co-pilots and everything like that. That it's an assistant that works with me. So when we're paying money, and we're gonna probably talk a little bit about that before we go out, is watching inference costs, etc. It's really you're equating to that to what FTEs what cost avoidance you have, and if this co-pilot is helping me, this coworker, if you don't want to brand it, is helping me. What's the incremental cost of that coworker helping me as opposed to the incremental cost of hiring that FTE and sick days and overhead and fringe and so and by the way, it's not replacing anybody because I have tons of open FTEs and I can't hire anyone. So we're just filling the open FTEs so we don't burn people out with the AI. But right now, nobody's losing their job. So just to make that very clear, but communication, augmenting the communication and just making it clear that this is an AI.
Yep. And a little bit, thank you, Michael. So a little bit of a lightning round here. We got about 7 minutes or so left. Want to keep us on schedule. Jeff, in the next couple of years, 2 to 3 years, what's one realistic way you see AI helping healthcare organizations, whether it's patient care, safety, operations? Like, think ahead a little bit. What are your thoughts?
Yeah, I often say it's a pretty tough time to be predicting the future of AI at this moment right now, given the speed with which things are changing. Some things are going to stay the same, procurement and governance and all those sorts of things are never going to go away. But the rate at which these tools are improving and the things they can do are improving is significant. I would say the optimism and the optimist in me is the reason why we started the Cancer AI Alliance is we believe that these AI tools can have a pretty significant impact on the way that we think about providing care for patients, but also in clinical decision support, incorporating all the information we collect about patients, whether that's the new kinds of information from recordings or whether it's the standard information we collect from labs or clinical interactions. And so I think for me, the hope is that as we all mature collectively in this space, that we'll be able to be more efficient about delivering care, certainly to reduce burnout, but also to actually directly improve care. I think there are a number of decisions that if you say, farm those decisions out to people who are overworked, overburdened, have a lot of things on their plate, have a lot of distractions, there's a lot of ways that we can help give support to those folks that can help everybody make decisions better. And I also think to the point that's been made earlier, many of these AI tools can help enable communication that's more patient-centric, helps explain complex topics to them in ways that's more understandable, helps to provide more regular updates. So I hope that that's the direction we'll go. And I think that the way we get there is really through really careful implementation of all of the things that have been talked about by Lee and Michael and others around the core blocking and tackling you have to do to be successful in the space.
Thank you, Jeff. Excellent. Lee, you want to look at the crystal ball for 60 seconds or so? Next couple of years?
Next couple years, I think that what we will hopefully see is earlier detection, including on the radiology side, especially the ability to look at everything from mammograms to cardiac MRIs and others where there might be a lack of, for example, specialists that can read those scans, or perhaps the human eye is only accurate to a certain extent, perhaps. And it's been proven that computer vision can be infinitely much more accurate. I think in the next decade, we might see the wonders of personalized medicine coming into play where, for example, for people who unfortunately do have cancer and may seek things like chemotherapy, we don't anymore have to overdose them to the extent where it's toxic. And being that a leading cause of death, unfortunately, is medical errors. My hope is that AI will help us to deliver better medical care, and that by doctors, nurses, and everyone in between being able to truly devote more time and focus to the patient, that their attention is freed where they do not have to fight with the technology as much. You speak to any kind of clinician or anyone that interfaces with patients, even hospital at home, let's say caregivers, and they will tell you that I spend a lot of my time fighting with technology. So if AI ultimately can help us develop much more efficient, much less error-prone software where we can do what we need to do patient side and otherwise, I think that that's a win.
Yep. Excellently. Mike, I'm going to give this last question to you, and hopefully in the last couple of minutes here. This came in from one of our attendees. And this is because you and I were talking about this a little bit yesterday. So this is specifically about ambient AI and transcription. How can, let me see here. There's another one I want to catch for both. Oh, so this is actually one I like for you, Michael. Within healthcare, I've heard organizations taking on roles and functions of licensed professionals, physicians, nurses, pharmacists. Since AI is not licensed by any state board, how is it held responsible for its decision-making when an error happens or a patient is injured? And this is a good one for you. So
Yeah, and that also gets to the legal and risk management people on your implementation team. But this is why our current deployments have a human in a loop. That it's that licensed provider making that is their face validity and what's going on. This is drive with my mental model of what's going on for the patient. We're just augmenting that mental model by aggregating data and then taking all that data and making knowledge for the provider to make good informed decisions about what's going on with the patient and have better line of sight into what's happened with other providers and other health systems, et cetera. But in the end, to be clear, that is very true. From a regulatory perspective, AI is not licensed. Now, that may happen in the future, but for now, it's my license. I get to practice medicine. The AI helps me practice medicine, just like a scribe or a technician or a nurse helps me practice medicine. And AI is just another coworker that helps me gain insights about what the right decisions are for the patient. But ultimately, it's my responsibility. And that's why you need good governance. And that's also why, as a patient safety officer, I don't let the AI make the decision because, to your point, how do you hold that responsible? In healthcare, highly regulated, very clear we can't do that. Robo-taxis, different thing entirely, and we can spend another hour on that if you want, but I know we have 30 seconds left, so I'll give it back to you.
That was fantastic, Michael. Thank you. We're really at time, so this is a fantastic conversation. I know we'll be publishing some of these playbooks coming up to make them very thorough and very easily digestible to everybody. But Jeff, Lee, Michael, thank you so much for the panel today. And Carol, I think we're right on time, so you can have a couple seconds back here.
You are right on time. Thank you all so much. That was terrific. I surely appreciate it.